about the state of the war against COVID-19 pandemic, the strategies that we're using, or as Professor Suru says, lack of strategy. We're still trying to understand what the challenges that the country faces and how to surmount them. And now I want us to take a look at some of the graphics that we have that will tell us how many people had been vaccinated as of some 2 days ago, and the total persons that had received the jab were 455,826, and out of this 455,299 of the AstraZeneca jab. Then the other 527 was Sputnik V. Then in as far as the vaccines that we have at the moment and those that are at different locations, at the national CVS, that is the store of vaccines in Kitengela, we have about 121,000 doses, and out of this from Gavi is 21,000, and a donation from India is 100,000. That's what remains in Kitengela. The total distributed to the 9 regional depots is about 999,000. So this is the stock that is in the 9 regions closer to the counties, and the total supply is 1.12 million doses. Something else is the vaccine stock that we currently have. Nairobi has a stock of 62,700 that is remaining, or was remaining 2 days ago. Then Nakuru had 60,000, Kisumu 48,000 for the region, Kakamega region for the western region is 38,400, Eldoret for the South Rift is 32,500, Nyeri region 19,500, Mombasa 3,000, Garissa 2,100, and Meru region 1,000 doses. Something else to look at is the stock that we have. Total stocks at the regional depots is 267,000 if you had to tabulate all those figures that I've just given you there. And then the vaccines that have been, or rather people that have received the vaccines, this is the distribution. In Nairobi, it's the highest with 32.4% at 147,521. Then Nakuru, 27,103. And then that is followed by Kiambu with 19,000 or 4.3% of the entire inoculation. Then Uasin Gishu has 5%, which is 22,841, and then Nyeri 14,687. Those are the top 5 counties. The bottom 5, you'll see that the counties, especially Lamu, has just 386 people that have received the jab, 898 in Mandera, Tana River 516, Marsabit 414, and Kwale 1,045 jabs already given to different people. And as we look at these numbers, let's also listen. Before you listen to that, Dr. Ngani, if you're still there, you look at those numbers, and of course you said that the inoculation program appears to have picked steam. But when you look at all that inequality, is it designed, or is it because Nairobi appears to carry the heaviest burden of the disease, that's why you have more people getting vaccinated in Nairobi? Or is it just about attitudes among the population?
Some actually, I would say it's all 3 things. And on this one, I would fully agree with Professor Suru's suggestion about strategy. Because if you look at our target as a country, we are proposing to vaccinate 30% of the population by the year 2023. That is way too late. With all the, probably most of us would have gotten COVID-19 by then. And so earlier on, when that looked like something positive, we've realized that now it's possible to vaccinate a bigger proportion of the population much earlier. Look at Rwanda, for example, proposing to vaccinate most of its population in 1 year. Look at the UK, what they have been able to do. Look at every other country out there, and also the impact of vaccination. So strategy-wise is the first thing, and perhaps we need to change the strategy and purpose to vaccinate a bigger portion of people within the next few months to help us come through this, because the cost is massive. The cost in terms of human lives, in terms of economic costs as well. The second thing is attitudes. And you'll notice that in places where COVID-19 isn't as widespread, then there's this perception that is still a myth, and that's not none of my business. See, it's you see that even in Nairobi, that was the situation a few weeks ago. Before we got deep into this wave, many people were hesitant to have the vaccine, partly because of hesitancy, but also without that, there was no concern about COVID-19. And you can see the exact same thing in far-flung counties where the number of COVID cases are probably 1 or 2. But with time, as COVID spreads, you will see greater uptake of this. And then the third thing is the question of design. And I think the distribution has been deliberate. I think the counties that are highly affected it makes sense to ensure that they're supported more. However, the number of vaccines we have in general is way too low.
And I'm looking at the numbers because in Nairobi you see 147,000 inoculated against a population of 4 million. That gives you about 3.6%, and we are to go all the way to 30% in 3 years' time. Looking at the challenges that we experience at the moment of the supply, do you think this is a possibility?
Well, so this is where government comes in, and government ought to come in strongly and secure vaccines for its population. Of course, we can go back and ask ourselves, why are we depending on countries like India, not manufacturing vaccines ourselves, understanding the capacity we have? Institutions like Cambridge are top-notch in research. So why are we not producing vaccines ourselves? I think that's one question that we should look back to and make amends for the future. But that notwithstanding, there are countries today that are securing vaccines for its populations. Rwanda, next door, intends to vaccinate almost everybody, I think, within 1 year. And therefore, those efforts have to be deliberate, and they have to go towards steps that make a difference. One such step is vaccination, and therefore, it makes economic sense, it makes social sense to transfer huge funds from the COVID funds and place in vaccination, then ramp up this vaccination season. One of the greatest pains I've had is facing a patient who has comorbid diabetes, hypertension. They're 52 years old and they want to be vaccinated. And I'm telling them, I know the risk is very high for this patient, but I'm telling them the vaccine is not for you. And I think that shouldn't be, because at this juncture, we know who's at risk. What you need to do is to avail what can help them, and vaccines do work, especially COVID-19 vaccines.
And Dr. you've said something, you're asking why we are not able to make our own vaccines, but I want you to reflect on the history of the country. We have many vaccines that people receive, whether it's polio or the baby jabs or flu vaccine, pneumococcal, meningococcal. Have you ever made any vaccine in this country?
Well, a lot of those vaccines, Sam, you'll be surprised, that a lot of those vaccines have been made in collaboration with Cambridge. I'll talk about malaria vaccine, for example. There are multiple innovations in healthcare that our own scientists in Kenya are involved massively in their production. The only problem is that most of these items are funded by external partners who take initiative and take ownership. If you go back, you'll find instances where Cambridge has been trying to get, there's a big row, I think a couple of years ago, between Cambridge and some university in terms of ownership rights. So we have capacity. What we have not done is to fund it ourselves and just set the strategy right to get us there. But this is one area where, if as a country we were purposeful, I would be leading in terms of innovation.
Right, and of course, Professor Suru is rejoining us. But Dr. Ngane, before I let you go on this topic, the question of adverse effects of vaccines, because this has been a bothering question, and many people are skeptical, saying that let me wait and see how people react to the vaccine. Sometime last week we had that report of a death related to a vaccine, but then again, PPB came out and said that it's not confirmed that there has been any fatality. Then there has been reports about the J&J that we now appear to be tilting towards. There has been difficulties in some parts of the world. Just how safe is it, and for who, especially with people that have comorbidities? Is it a good dose to take?
So I'll start with the last question. Right now, if you have a comorbid condition and you have the chance to get the vaccine, please run and get that vaccine right now. Especially if you have obesity. I think that's one that we are missing out, and it's quite important. A lot of people, young people in their 30s, are getting severe and critical disease. The only comorbid condition is obesity. Then you have high blood pressure, high sugar. If you have any of this and you have the chance to get the vaccine, please get the jab, because it is safe. The biggest risk factor that has been reported is clotting, and this clotting can be fatal. It has potential. But look at it this way. They're talking about 40 clots out of more than almost 17 million, though now it's being revised to about 1 million. COVID-19 itself causes 4,000 times more clots than the AstraZeneca vaccine. I'll say that again. You have, actually not 4,000, 40,000 greater risk of getting clots from COVID-19 than you have from the AstraZeneca vaccine. And therefore, if your reason for not taking the jab is because you're afraid of clots. When you get COVID, that risk increases 40,000 times. And therefore, you can see why that is not a factor. In fact, from taking the pills for contraception alone, your risk of getting COVID-19 is about 10 times more than from the jab. No, from getting clots is 10 times more than from the jab. And so this can I say, anxiety that is being spread by a lot of people who may not be qualified to spread that is creating a lot of hesitation and is actually costing lives. And therefore, just to reassure the population, yes, there are some risks with every drug that is given out, including vaccines. And yes, there could be some of those risks can be severe. In fact, just from taking paracetamol alone, there's risk of death, there's risk of liver failure. There are many risks associated. But then those risks far outweigh, the benefits far outweigh those risks.
Okay.
And COVID-19 is one such scenario.
There's something you've mentioned there. I know we are talking about COVID, but I would not let it slip because someone might be paying attention. You said that family planning and clots, maybe you can clarify on that?
Yes, so I was just giving the example of the clots, the risk of clots, because it's been quite hyped, the number of clots that have been gotten from this COVID-19 jab associated. It's not proven. And one may think that now this is the thing that is causing clots. But in fact, even without the jab itself, the risk of clot is still there. And it's there for many other common things that we take without second thoughts. And one such example is the family planning pills we take. The risk of getting clots from that is more than 10 times the risk from taking the COVID-19 vaccine. And the most important one, some that don't want to miss, is that the risk of getting clots from COVID-19 itself is 40,000 times more than from getting it from the jab. And therefore, that tells you, if you're avoiding the clot, you better take the jab.
All right, and Professor Osuru and Dr. Nyikala are back, but I want us to listen first to some voices talking about the challenges of the supply of the COVID-19 vaccines.
We have received on the continent. We have vaccinated just about 60% of the vaccines that we have received. We are very far away from our target of 750 million people being vaccinated, and we are working extremely hard to try and get those vaccines onto the continent within this year of 2021.
In a good vaccination program, predictability of availability of vaccines is very, very important, so that you know when and how to use your first doses, and how to counsel people that have received their first doses to come in and get their second dose. The situation with the Serum Institute and the government of India imposing restriction, it makes it very complicated for our vaccination program across the continent.
COVAX, their estimation is that they will be able to cover 20% of the African population. That means we have 40% to be able to look for resources to cover that gap. And that 40%, we will fill it in two ways. One is to buy directly, and that is what we are doing as Africa CDC and the Africa Union. We buy what is available out there. And second is bilateral arrangement, whether it is donations or our country may have taken a loan somewhere.
Right, and those are Dr. Ahmed Ogwell, Deputy Director of Africa CDC, as well as John Kengasong, who is the head of Africa CDC. And let me begin with you, Professor Osuru, and the challenge of vaccine supply. You hear Dr. Ogwell there saying that we may get up to 60% from COVAX, but we're very far from that, because if you look at the number of people inoculated, just about 500,000, that gives you about, is it just 1% of the entire population? Do you have a strategy?
Yeah, so the vaccine program is very difficult. I'm calling it a program because it goes beyond availability of vaccines. Right now, we are struggling with availability in many fronts. One, the demand for vaccines is much higher than the supply. Secondly, the richer countries have made orders to the manufacturers, so they have basically mopped what is available and what we call vaccine nationalism. where people think more of their countries than the rest of the world is happening a lot in the rich countries. So we were depending a lot on the supply from India. Then India has gotten into a crisis. They have many cases, so they are not exporting. So even if the COVAX was to work, that facility for supplying vaccines to the poorer countries, we have a problem of shortage. But beyond that, when I talk to Africa CDC, there is another problem. And the problem we have is that the vaccines that have been brought to Africa, again, are not being fully taken up. You may have vaccines, there is no assurance that people will accept those vaccines. And there is a bigger problem which is in the offing, and that is whether communities really accept these vaccines, the vaccine readiness at community level. You might think that because Kenya imported 1 million vaccines and people seem to be scrambling for them now, that the demand is actually there. These vaccines were first imported for frontline health workers and essential workers, the doctors, the nurses, the police, teachers. What happened in the few days when the vaccines were introduced, we realized the uptake was very low. So we opened it up to people above 58. Then the demand went a little higher. It tells you there is a problem in communities. We've done some studies, and we will be making them available in the near future in another few weeks. But what is being shown in these studies is that communities are not ready. They don't have information. There are lots of myths about the vaccine in the community, and we are not putting money there to prepare these communities with the right information. In fact, the anti-vax messages are flooding the communities. The anti-vaccination, the myths about the vaccine, the negative things about the vaccine is what people are hearing.
Right.
For a vaccine program to succeed, and I know Dr. Nikali is a pediatrician, he's at the center of vaccination programs, he will tell you that you need a lot more money to prepare communities, to educate them, to have them have a positive attitude towards it. Then you will have a successful campaign. Right now, if we got 5 million doses, most likely some of it will expire in the shelves. And we need much more doses even than that. Let us have a strategy again here on how to vaccinate, to procure, to distribute, to prepare health facilities, and to prepare communities. That strategy is needed.
Right. It would appear you have many problems, not just on uptake, but specifically on the supply, because now there's that uncertainty. And Dr. Nikal, if nearly 500,000 people have already been inoculated with the AstraZeneca jab, there's been that question about, will those people that have received the first jab be assured of the second jab? We have heard from no less than the president saying that we assure you that you'll get your jab. But realistically, I saw Dr. Akhwale saying that whether the AstraZeneca jab is late or not, they are certain that they'll get it before the 12th week of the first jab that was given in the country. Are you confident? Can you confidently say that we will be sure to get that, despite the challenges with India holding back, and the fact that what the people are calling the nationalism, the vaccine nationalism?
We've called the Minister of Health to the Health Committee twice, and I think even tomorrow, and we have that concern. One, shall we have the vaccines? Have we applied internationally? Are we on the waiting list, and how far are we? Two, what we have got now, will people get the second dose? And they have assured us, and I'll use the word assure, that they are ready for it. Those who have got about 500,000 people will get the second dose. I think that's as much as we can take. When the ministry says they have enough, we visited, the committee visited the depot in Kitengela. We were shown the drugs, the vaccines that are there. The question is, in that visit, you probably cannot ascertain the numbers, but we have the vaccines there. So I think we must have some faith now. If the ministry comes out, if the government comes out to the highest level and says we will get it, that is where we are. But as a health committee, it is something we are monitoring very carefully, the issue of vaccines in particular, because as Professor Sur said earlier, we would expect that if we have adequate vaccination and we reach a level where we have herd immunity, enough people are vaccinated to protect the whole population, then that will bring issues down very, very quickly. So we have faith that what the government is telling us, the executive, let me say that, the executive is telling us is that they will be able to get the second vaccine. However, as regards the number that we require, because even we are worrying about the second dose, but the number we require is much, much larger than that.
Right.
That is where we have an international issue. Dr. Guel was saying that COVAX is trying to buy with AU and Africa CDC. We only have hope that they will. When we know that the manufacturers like the Serum Institute in India is now saying they are people first, then I think there's a global challenge for this, and we only hope that the international community will rise up to it. First, just in production, leave alone the ability to purchase. It has to be there before it is purchased. Our concern a lot at the health committee is the financing of it. We saw this when the ARVs came, that we get support like we are getting from COVAX now.
Right.
And if we don't ourselves plan and set aside money and know that sooner or later we will need to pay for it ourselves, then we may be in for a problem. So we are pushing, the budget is coming, and I think the issue of making funds available for vaccination and COVID in general will be a critical issue that we'll have to look at as Parliament, the budget comes on.
And Dr. Ngani,
I wanted to say something about sensitization, and Professor Sur indicated that I'm a pediatrician. If you look at when we are going for polio vaccines, polio vaccination, even measles once, but polio we have done much more times. The amount of information you have in the air, when it will be done, where it will be done, you actually have a little campaign, just like a political campaign. You see it on TV, you see health workers on the ground moving around, you see them in colorful clothing, and people know that those are the vaccination people coming. I think we also need to do the same with the COVID vaccination. We really have to, sensitization has to come up a little more.
Right.
Because right now we have a lot of information in the social media, in the print media, and if it's not countered with information from government reliable sources, then what is in the media takes root, and it will be very difficult to get people to accept. But let me say one thing: it is much safer to get this vaccine than not to get it. The risk of dying from COVID in this country is much, much, much higher now than the risk of dying or getting sick from the vaccine. And let me add, even I think the risk of dying or getting hurt from the vaccine is much less than the risk of getting in a car from Nairobi to Kisumu. That is the message I think people would like people to have.
Very, very interesting there. And Dr. Ngani, because of the uncertainties with the supply of the vaccines, what do you think is the better thing to do at a time that you're not certain about mix and match, even as the country starts talks, or is it African Union starts talks with South African authorities on whether they can get the J&J jab? What do you think we should do? Because if we hit the mid-mark of 550 or thereabout, or 600,000, should we stop vaccination of the AstraZeneca jab and keep it for the second dose, or continue in the hope that we might be lucky?
I think the government had made a decision on, the Ministry of Health, very early on during the sensitization around vaccination campaign. I think we as vaccinating centers, we were informed that the ministry would release half the vaccines to guarantee the second half, that the second half will get the second jab. I'm not sure that this has changed, but as of 2 weeks, actually a couple of weeks ago, this was a strategy that was in place to ensure that everybody who gets the first dose gets the second dose. The move towards the J&J jab, the J&J jab has its own advantage, the biggest one being that it's a single dose. You just get the jab once and that is it, which logistically is much better, and also in terms of the time to getting, sort of some level of immunity, that's also lower. But it's important for us to, even as we're saying that this vaccine is safe, to let people know that yes, there is some risk to it. And what are these risks? The first and the biggest one is that you will get symptoms such as those of a common cold. I had in some instance someone claiming they could have got COVID-19 from the AstraZeneca jab, and I want to say that this is not possible because the AstraZeneca jab is something called a viral vector vaccine. And viral vector means that we've taken another virus altogether, in this case adenovirus, which causes a common cold, and put some RNA, some material, genetic material from COVID-19 into this and then given it out. So you cannot get COVID-19 from the AstraZeneca jab. This is the first important point. But because it's a different kind of a virus, you can get symptoms of a common cold. You can get some pain on the site of injection. You can get a fever. You can get some sore throat, slight cough. You can have some joint pains. These are the more common, not very common, but the more common symptoms that then resolve in a few days. Therefore, when you look at it, at the big picture, yes, there may be some discomfort around it, but the safety that comes with it is much, much better.
There's a specific question from Engineer Lazaro, who says there's a possibility of Kenyans receiving second jab from different brands of vaccine. What are the risks? Do we know? I mean, I know that the studies are not yet conclusive, but is there any safety? Is there any harm?
Yes, so at this juncture, it's not recommended to mix vaccines. But then in China, the study is ongoing right now around combining different types of vaccines to see the impact of that in terms of the overall immunity. And that is too early to tell. Currently, the advice is to, if you take the first dose of a particular vaccine, get the second dose. But it's also important to understand that all these vaccines have shown tremendous benefit. Against symptomatic disease, the AstraZeneca vaccine and the J&J vaccine are about 60%. But that's not the issue. The main issue is severe and critical disease and also death. And in multiple studies, these jabs have been shown to have almost 100% benefit. And therefore, to that end, whatever vaccine you get, that should be good enough for you. The important thing is to get access to it.
Okay, access. And they want to correct something that I said earlier, that 56 people are currently under ventilator. According to the statistics from the Ministry of Health, it shows that 256 are in ICU. It's only 44 that are under ventilatory support. 181 of those in ICU are on oxygen supplementation, but a whole other 257 patients are currently on oxygen supplementation, both at the HDU and the general wards of different facilities. The number at 1,660, the patients that are currently in hospital, and 5,994 under what is called home-based care, as announced by the Ministry of Health. And now I want us to transition to another topic. And unfortunately, we have highlighted the many challenges that we face, but there's a bigger challenge when it comes to how we spend our money. And there's the report from the Auditor General, Special Auditor's report, that shows of how there could have been some improprieties at different countries. Let's just look at those numbers. The alleged misuse of COVID-19 funds.
Can I say something about the mix and match before we move there?
Let me take you through these slides, and then you can talk about that. Don't worry. The lack of procurement plans in Bomet, Bungoma, Elgeyo Marakwet, Embu, and Garissa counties. So they didn't have a proper procurement plan. Also in Homa Bay, Isiolo, Kakamega, Kericho, Kirinyaga. Already these 10 counties. Then the lack of procurement plans, Kwale, Machakos, Mandera, Migori. You see that many counties affected when they received 13 billion shillings in response to COVID. Then they may have contracted private firms to deal with the response to the pandemic. Embu, Homa Bay, Isiolo, and Murang'a counties. Then something else that was noted by the Auditor General as an irregularity is the lack of market survey in Busia, Kakamega, Isiolo, Marsabit, and Meru. This is at the start of the pandemic last year. Then splitting of contracts was reported in Bomet, Kisii, and Meru that the Auditor General feels was inconsistent with what should happen, then misused the Kenya Devolution Support Program funds in Bungoma and Kisii County. And something else, misuse of COVID-19 funds, the lack of competitive bidding in the counties of Baringo, Busia, Homa Bay, Lamu, Mandera, and Marsabit. So I don't know whether these are challenges that are occasioned by the circumstances, or it was a problem of what the Auditor General says, improprieties. And Dr. Nyikao, you wanted to respond about mix and match. As you do so, please go ahead and say something about the expenditure that you've seen. I remember last year when there was a special audit report by the Auditor General, there had been challenges in expenditure, different counties, and now this comes out and you see that we didn't do what we were supposed to do. Is it a question of not knowing what to do within a pandemic, or is it just sheer mismanagement?
Let me start by the mix and match. I think there's an important issue to look at when you're taking different vaccines as a country. One, I think, has been said by my colleagues, and if you take one vaccine, the next one should be the same, the second one. Remember that their timings are also different. But mine is the logistics issue that will come with, say, 2-3 different vaccines being applied within the country. Already with one vaccine, we are having a lot of logistical issues. Imagine we now have 2 or 3 vaccines which have different timings, which we have to explain the complications if they are there differently, and which we have slightly different cold chain requirements. And my view, this is just my view, it is good to actually have one vaccine, decide that it is the best for us, like we decided on AstraZeneca, on the cold chain and on the availability, so that we get good at using that vaccine. We develop a system that uses it. If you bring too many at the same time with our system that is weak, then let me just take a simple example on advising people. We know we had Sputnik appear here. It appeared temporarily, and then which is 3 weeks for the next vaccine. And we have AstraZeneca, which is 8 weeks. Now imagine if you had that, and now you want to educate the people on when they should go back for their next vaccines, even the health workers, I think it would be different. So my view is that we should look clearly at what is best in our circumstances, looking at effectiveness, looking at the cold chain, looking at the cost, and stick to that. Now, if then we find there is a better vaccine that has come, then we actually then plan to change over and actually have a clear transition plan so that we don't get a lot of confusion. I'm worried of the confusion that will get in place. And let also add that the issue of the private sector use, again, must be within the same policy, same strategy, same application. In terms of paying for it, I think we should not bring a cost element in the vaccines if we can afford it. It will be chaotic. Now, let me go then to your issue of the expenditures. Well, you talked at the counties, but I think even nationally, the biggest problem we had with accountability was actually at KEMSA. And I think the whole country knows about that.
Right.
So there is a problem of accountability that has occurred. And in the counties also, you have listed the issues of procurement, and splitting contracts and the lack of competitive bidding. It's all procurement. But there is also another issue there that we noticed, a delay in using the money. Last time when the money was given out, some of it went a bit late, and so it wasn't used in time. And but in some cases, it was too little, like hiring of health workers. The money was available for only 3 months, while the health workers were actually to be on for a longer time. I know that has been corrected. But the overall issue here is, in a pandemic, there has to be a national plan that everybody falls into. The counties can do it, but they have to do it in the context of an agreed plan, an agreed process, and agreed guidelines. Now, there's an issue we have with the devolution. I don't think it's just in health, that the national government, the national ministries, they are in charge of policy and standards, but actually there's no good process where they can enforce those upon the counties, so that you have people doing different things. My view is we must have one strategy, one national process. The counties can then do it, but with that guideline. Otherwise, we'll have a lot of problem, even with the disbursement, which to a large extent is a national issue. Where counties have issues, they actually need support. There is a intergovernmental relations structures. They need to use those so that the counties all do the same thing. Remember when the money was given out, when they were to make beds and ICU beds, money was given out, they were not used equally or the same way in all the counties. We went out and we found that there is some cases where there was money to actually for purchase of some requirements,
right?
And there were even donations. So you didn't even find harmonization between what you get through the donors and what we buy. But as I said, we need one national strategy, one national plan, one process. Counties can then adopt it a little bit to fit them, but that need is to be there. And the national, in a pandemic, the national government has to actually drive the process and assist the county government. If you leave it to them alone, I don't think it will work well.
Okay, all right. And let me get to you, Professor Osuru, before Dr. Ngani, because when the counties receive this money, I'm looking at a figure of 7.1 billion shillings from the National Treasury. Of course, part of it coming from donors. The Kenya Devolution Support Program was supported by World Bank, was 849 million shillings, and then another 5.2 billion shillings from local sources. When they received this money, they were supposed to now finance their response strategy in the counties. So it's about procuring protective gear, whether it's supporting their healthcare workers, or it's getting sufficient beds, whether it's for isolation or for treatment. How would you explain these challenges at a time that now the auditor is coming and flagging and saying that there was a bit of impropriety in majority of the counties?
Yeah, I think it has been said severally that COVID exposes the weaknesses in the system. We have existing weaknesses. So when you have an emergency procurement to do, then those weaknesses become obvious. What the Auditor General has exposed, I hope there is no misuse of money. It appears like inability to stick to systems that are recommended. And so what I think is necessary to alleviate this kind of a problem, because the other problem we may have is that when people try to follow those weak systems, it may take too long to respond. Mm-hmm. So what may work under an emergency circumstance like we have now is an agreed national framework, and I think Dr. Nyikala has talked about it. And we can also, there are things which can be done at national level. If the national, assuming the national level systems themselves are strong enough, one can procure and distribute, like now we are doing with the vaccines. Mm-hmm. We could do the same with other products, including beds, but we also know that maybe at that level, the system is not as strong either. So it's just an existing system problem which needs to be tackled at a higher level. Parliament maybe needs to do something about how we implement the existing policies, what kind of people we have at the counties to implement those recommendations or those policies. I think some counties are very weak, some are strong, and now you are seeing those discrepancies in the way they are doing things.
Mm-hmm. And Dr. Ngani, because many a times that you're told there are challenges in the public sector, maybe you should borrow some lessons from the private sector. What did you do at a private facility that now you have a pandemic, you need to do things differently, not just as yourselves as the staff members, but also how you're going to respond because it's a health delivery system that you run? How did you do it to ensure that you're able to do emergency procurement and deal with the pandemic as a new thing that you haven't known previously?
Well, I am tempted to respond candidly to your first question, but first, in terms of what you're asking me directly, in the private sector, what we want to do is to enhance efficiency, to enhance how we utilize the resources we have to achieve the greatest possible. And so, if, say, for example, for every 100 shillings that you see in government, we probably end up using about 10% of that and getting value in that regard. We've had to look at, for example, the use of oxygen. In our facility, we ended up investing in piping we had piping before, but we ended up putting piped oxygen for every other patient who will need it. This way we have efficient utilization and very little wastage because it's going through a well-controlled system. Constantly in the private sector, we are scanning the market for the least expensive, high-quality supplier. We maintain quality, but then also keep looking for a cost effectiveness because you know that the costs have gone up tremendously. One of the biggest pains we face as a country is that whenever there is what is called government money involved, there are those people who salivate and they're just waiting for the opportunity. And it's the saddest thing that we face as a nation, that even in the midst of a pandemic of this nature, there are people who are seeking to profit, not by delivering something in particular, but by using those funds to divert them other cases. And the truth is, when this is looked at deeply, we will find that there are many, many people who have been involved in taking away funds. If you look at the amount of money we have placed in COVID-19 funds, it's mind-boggling. Yet, today there are families struggling with ICU bills. You're saying there are 44, I think it's much higher, but you're saying there are 44 patients in ICU today. It means that if as a country...
It's 44 under ventilator, but 256 in ICU.
Yes, so the patients on ventilator, for example, we are able to support them by 1.5 billion. If you maintain that number throughout the whole year, 1.5 billion would take that pain from those families. Right now, families are having to pay over 100,000 shillings every single day to treat COVID-19. If they're 156 sum, it means that for about 4.8 billion in 1 year, we're able to support those families and take that burden away from them. In a whole year, by the way. So if you look at the amount of COVID funds we've put in place and the kinds of equipment we're seeing, you get concerned. You're seeing some counties buying what are called CPAP machines at the cost of a ventilator, something being bought for almost 20 times the cost. We are looking at people putting up oxygen plants that cost about 14 million. People want to put them up for over 100 million shillings. You are seeing people, it's this sadness where it's become normal and acceptable to steal public funds. And it's because of what? Impunity. We know that nothing happens. We have had a big discussion around cancer. You know, a year down the line, where are we? And until as a country we determine that in the area of healthcare, we understand that theft there will cost lives. And if you were to put your fingers in public coffers in the health sector, you will definitely go to jail. Until that becomes our reality, we'll keep facing these issues. Because the truth be told, the amount of money allocated to COVID in this country is enough to make tremendous changes in the health sector. That's the reality. If you gave that money to, say, for example, my boss who runs the healthcare group, we will build probably more than 150 hospitals of our level and run them with COVID and actually support the patients. But you're not doing that. Why is it not possible? The same facilities we have that are working in Nairobi that are private, why is it not possible to have similar facilities in the government? Let's ask ourselves these basic questions. And at the bottom of it, it will be a leadership issue, an accountability issue, and an area of just our morals and ethics. And perhaps as a country, you know, we make a decision to finally say just get rid of this corruption business because it's killing us.
Right. And I don't think there's anything more useful to add to that. We understand that the Health Committee of the National Assembly, the one that Dr. Nyikal sits, has invited different health executives from different counties to come and respond to queries raised by the Auditor General starting the 19th of this month. That should be Monday next week. We'll be sure to bring you the latest as soon as that comes in. But gentlemen, I want us to wind up by looking at some of the feedback that you've received this morning. You've been tweeting the show via Citizen TV Kenya, Sam Gituku, hashtag being daybreak. And Jenga, you're saying that taking care of patients at home is risky because we don't know how much care they are. I think total lockdown, as in the instance, would work in helping drop the rate of spread. Astronaut KE, you say we still don't know what we don't know about coronavirus. The government of Kenya statistics seem amenable to opportunistic interpretations and therefore lack credibility. Baba Narasha, as I cross borders daily, let me confide to you that there are zero testing going on. What one needs is only 2,000 shillings. Thousands of Kenyans cross daily to and from Tanzania, Ethiopia, Somalia, and Uganda for business and taking their kids to school across since March last year. Eric Nyamwea, so you test negative because you are symptomatic. I know people who are symptomatic but tested positive. In fact, we can't call them asymptomatic if they don't test positive. Well, very interesting there. You can get the virus, but you're symptomatic, meaning you don't show any symptoms, or you may show some mild symptoms, but you may also be symptomatic in a sense. I think currently it's about 8% of all the cases that are positive. Thank you so much, Dr. Victor Ngani from RFH Healthcare, and also a critical care doctor. Thank you so much, Dr. James Nikal, MP Seme, as well as a member of the Health Committee, and Professor Joachim Osur from AMREF Health for joining us to have this conversation. We'll do this again, but it's a continuing conversation as we find solutions to those things that boggle our minds, that you don't know what to do. Up next is Sporty Monday with Mukami Wambora, but I'll be back at 9 o'clock as we wait for the start of the interviews